Okay, so we got some fun stuff to talk about now. Nephrotic syndromes with the renal pathology. The first one let's talk about is minimal change disease. Minimal change disease, this is the most common nephrotic syndrome seen in children. So what happens in this disease is we're looking at this picture right here. Well, T cells and cytokines injure visceral epithelial cells, which are known as podocytes. Now, these podocytes and podocyte foot processes, what happens is when these T cells and these cytokines hit them, they lose their negative charge and they become effaced. And this is highly selective for protein because that's what causes this big hypoalbuminemia. They got low albumin in their blood, so their bellies are going to swell. You're going to see podocyte effacement, and you can see it all through here as you look at this picture right through here. You see these right here. Now notice the glomeruli look normal though, but the effacement of the podocytes, that's a simplification. All right, it's really kind of a flattening. All right, so you're not going to see much on. Another thing before we get to that, you're going to have a defective glomerular filtration charge barrier because remember, podocytes are charged. They're negatively charged proteins sitting on the outside to repel negative charges such as proteins to keep the oncotic pressure in the blood high. So you're going to have an increased filtration of subsequent tubular resorption of lipoproteins. That's why you get lipid-laden proximal tubular cells, also known as lipid nephrosis. Write that in there for you. That's really important that you understand that. That's where that comes from, lipid nephrosis. On immunofluorescence, you're going to see no depositions. On light microscopy, remember I said you're going to see a normal appearing glomeruli with lipid-laden proximal tubular cells, and we just talked about that. But on electron microscopy, on EM, you're going to see diffuse effacement of the podocyte. So on the EM, diffuse effacement. Podocyte. Now remember, this is usually going to be in a child commonly 2 to 6 years of age. That's the big thing to know there. Sometimes a recent history of respiratory infection or routine prophylactic immunization, they're going to present with massive proteinuria, signs and symptoms of nephrotic syndrome. However, their renal function is usually good, and there is usually no hematuria or hypertension. So there's a good response to what? Corticosteroids. Great response in minimal change disease to corticosteroids. So let's talk about focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis is the most common cause of nephrotic syndrome in adults in the U.S. So think adults, and you think this guy. Most common cause. So look at this picture and get it in your mind, all right? So why is it focal segmental? The sclerosis of some but not all the glomeruli, hence why it's focal. Within the affected glomeruli, there is sclerosis of some but not all the glomerulus, and that's why it's hence segmental. Now, the pathophysiology is possible cytokine-mediated damage and focal disruption of, again, podocytes, visceral epithelial cells. So foci of increased permeability. There's entrapment of plasma proteins. Therefore, you get sclerosis. You get hyalinization. No, there are no immune complex depositions in focal segmental glomerulosclerosis. This is not a type 3 hypersensitivity reaction. Now, on light microscopy, you're going to see sclerosis. See all this scarring in here? The scarring right here. That's on light microscopy. On immunofluorescence, you're going to see IgM and C3 may be observed in sclerotic areas, but however, there are no complex depositions that are visualized on immunofluorescence. So this is not an immune-mediated reaction. On electron microscopy, you're going to see diffuse effacement of podocytes. So focal segmental glomerulosclerosis is basically minimal change disease in an adult. But the risk factors include what? Blacks, HIV infection, IV drug user, and sickle cell disease. Also obesity and certain things like that. Now, they have a poor response to corticosteroids, unfortunately, like minimal change disease. So, this is a poor prognosis. Above 50% of patients develop end-stage renal disease within 10 years. So, this is not a good thing to have once you're an adult. Kids can handle it, but there's too much sclerosing and there's too much glomerular hyalinization and sclerotic in this one. What about membranous nephropathy? Obviously, we can see this is lightened up, so we know we've got immune deposition here. So, what do we know about membranous nephropathy? With membranous nephropathy, it's the second most common cause of nephrotic syndrome in adults in the U.S. It's also called focal segmental glomerulosclerosis. Actually, that's what we were just talking about. That's the most common, but this is the second most common. So this guy gets number 2. Membranous nephropathy, or membranous glomerulopathy. The pathophysiology behind this, like we said, immune-mediated, immune complex deposition on the glomerular epithelial basement membrane. So you're going to get activation of the complement cascade. So C5b through C9 membrane attack complex damages the glomerular epithelial and mesangial cells, causing their release of proteases and oxidants, which further contribute to glomerular capillary wall damage. So you're going to get nephrotic change, you're going to get proteinuria, etc., etc., etc. Now, on light microscopy, you get a normal appearing glomeruli. See, look at this right here. This looks kind of normal, doesn't it? See that right there? This is immunofluorescence, by the way. Just in case you didn't know, this is light microscopy right here. You get a silver stain, you get a spike and dome. Remember, I'm just giving you the high yields here. You get a spike and dome appearance on silver stain. On silver stain right there. The spikes are the basement membrane material, and on immunofluorescent microscopy, we get a granular deposition of IgG and C3. So that's the 2 things I want you to remember. Right here, IgG and C3. Okay? Now, this may also cause renal vein thrombosis. That's a very high yield thing to be aware of. Renal vein thrombosis, the second most common cause in adults of nephrotic syndromes, membranous nephropathies. That's the one that's going to get you. Although 85% of cases of membranous nephropathy are primary idiopathic, there are a variety of causes of secondary membranous nephropathy. We're going to go through a few of them here. I'm going to get a new page, and we're going to go through just a few of these guys. So, like hepatitis, B, C, syphilis, malaria. These are all infectious diseases. Autoimmune diseases like SLE, lupus, RA, Sjogren's disease, Hashimoto's, thyroiditis. Drugs, penicillamine. Because remember, this is immune-mediated captopril. Even an ACE inhibitor there. NSAIDs. Ooh, that's a big one to remember right there. Definitely remember that one. How about gold? They get too much gold in their system. I don't know, somebody maybe swallowing gold. Malignancies, solid tumors. Like colon carcinoma, lung carcinoma, or melanoma. Also CLL, chronic lymphocytic leukemia. That's another one that can cause secondary membranous nephropathy. So I hope that gives you a better understanding of the second most common cause of what's seen in adults in the United States. Remember, it is immune mediated, whereas focal, the number one cause, which is just basically minimal change disease in adults, focal segmental glomerulosclerosis, is not immune mediated. You're not going to see anything on immunofluorescence. You want to see stuff on light microscopy and EM. But how is in membranous nephropathy, which is the second most common cause, you will see because it is all over the immune system. Here's all kinds of reasons. So membranoproliferative glomerulonephritis, MPGN, what is this? So I want you to note here, membranoproliferative glomerulonephritis, I'm just going to call it MPGN, is not a pure nephrotic syndrome, so the clinical presentation includes both nephritic and nephrotic features. So in the adolescents or young adults with nephrotic syndrome and a nephritic component, so you're going to have some hematuria, and there's going to be a slow progression to renal failure. Now look at the glomeruli right here real closely. As I write in hematuria, you will see that in this. Common to both, there's two types here. There's type 1 and type 2. And common to both types, the glomeruli are large and they're hypercellular, okay? And this is due to the white blood cell infiltrate, proliferation of mesangial cells and endothelial cells, and increase in mesangial matrix, all right? Also notice the duplication and the splitting of the glomerular basement membrane. Can you see this right here? Can you see this splitting? See that splitting? See that splitting right there? Right through here. Look at all that right there. Splitting. Glomerular basement membrane. Seeing both type 1 and type 2. So, MPGN type 1, what do we see? We see, let me get a new page for this right here. We see subendothelial immune complex deposition. So you know it's going to light up on microscopy, right? Of C3, IgG, an early complement of C1 and C4. All right, what about, it also activates both classical and alternative complement cascades. I want you to know that right there. Activates alternative and classical pathways. This right here, guys, I'm sorry, it's just straight up memorization. So type 2. This is the dense deposition disease, okay? This is intramembranous. Immune complex deposition of C3 and IgG only. Okay, so we got some differences here. In type 1, what do you got? You got subendothelial immune complexes of hell, just about everything. You got C3, IgG, C1, C4, so you see you get subendothelial. Here you get intramembranous of only C3 and IgG only. So that's a huge little clue for you there between the two types. And I'm going to get another page here because there's also 4 types of things they call secondary MPGN. Number 1, autoimmune. Imagine that. Autoimmune disease, chronic immune complex deposition. And for example, SLE, Sjogren's disease. So number 2, infection, for example, same things before, like Hep C, Hep B, HIV, schistosomiasis. What do you think of? Bladder cancer. About number 3, alpha antitrypsin deficiency. That's a good one right there. That could definitely hit you on that one. And then malignancy, again, CLL, and lymphoma. So look at the key differences, or look at the key right here. I'm going to take you a couple slides back. I want you to notice something. And these are all secondary causes, but the CLL, the hepatitis C and V, all of this, SLL, Sjogren's, look back up here, right here. See the CLL causing what? Secondary membranous, this most second common type seen in adults, membranous nephropathy, immune-mediated CLL. See that right there? See Hep B and Hep C right here. Sjogren's, lupus, so solid tumors. So moving back down here, look at this one. This one kind of stands out. So alpha-1 antitrypsin deficiency can do what? Cause a secondary membranous proliferative glomerulonephritis. But it's secondary. Don't think type 1, type 2. If it's type 1, you go subendothelioid immune complex deposition of just about everything, and also alternative classical pathways are activated. But in type 2, it's intramembranous, and it's only C3 and IgG only. That's huge differences, guys. So hopefully that clears up nephrotic syndromes for you. I know those are very complicated, and it's a lot of information to learn. So hopefully, if you watch this a couple times, you should get those down.